transducer in an AP position and the subcostal window. We're going to look at the interpretation in a step-by-step fashion also. So in step 1, you're going to have the transducer in an AP position, and the main thing you're going to be able to visualize is the liver and the inferior vena cava. Now remember, the inferior vena cava can provide you with a non-invasive CVP reading. Its respiratory variation can provide you with clues into whether or not the patient is going to be fluid responsive. In assessing the inferior vena cava, it's been shown that the inferior vena cava correlates very well with central venous pressure in the spontaneously breathing patient, not in the mechanically ventilated patient. An inferior vena cava that's less than 1.5 centimeters and collapses greater than 50% with inspiration correlates with a CVP of between 0 to 5 millimeters of mercury. An inferior vena cava that is between 1.5 and 2.5 centimeters and collapses about 50% during inspiration correlates with a CVP of about 5 to 10 millimeters of mercury. A CVP or inferior vena cava of 1.5 to 2.5 centimeters that collapses less than 50% correlates with a reading of approximately 10 to 15 millimeters of mercury. And an inferior vena cava of greater than 2.5 centimeters with little respiratory variation correlates with a CVP reading of 15 to 20 millimeters of mercury. In the cardiac module, we'll show you how to measure the inferior vena cava in a longitudinal fashion using M mode, but here we're just going to do qualitative assessments using naked eye evaluation. Here are two different inferior vena cavas. You can see in this patient on the left who was markedly hypovolemic due to blood loss that the inferior vena cava was almost slit-like, and it was completely collapsing with respiratory variation. So this was a patient who globally had a very low CVP and would be in need of fluids. Here was a patient who, on the other hand, had a very plethoric round inferior vena cava and very little respiratory variation. This would be suggestive of a high CVP reading. At this point, we still have not yet reached the heart, but as we're angling into the chest, we're able to get a window into the peritoneal cavity using the liver here, but we're also able to see the thoracic cavity. So in this patient, before we've even reached step 3 or step 4 and have gotten to the heart, you can see that there is free fluid surrounding the liver. Since this is surrounding the liver here, this would be intraperitoneal, but we can also see on the cephalad to the diaphragm here, because this is anterior inferior, this is posterior superior, here we're into the chest. So this would be a right pleural effusion. So even before we've gotten to the heart, we're able to see that there's a large fluid collection within the abdomen as well as within the right hemithorax. Now we continue to angle into the chest, and right now we're at about the level of the right atrial caval junction. So now going back to this patient, remember they've got a large intraperitoneal fluid collection, a large thoracic fluid collection on the right. As we continue to angle then, there you follow the inferior vena cava, you're at the junction now, there's the heart, and again, on the subcostal window, there's going to be an intra-abdominal window here, there's going to be an intrathoracic window on the right. So you've got to keep in mind that you're going to see other potential fluid collections here, and you have to look at what the shape of the container is before calling anything on a subcostal window a pericardial fluid collection. Now this patient did have a small pericardial fluid collection also, but this patient has a very large, like I said, peritoneal, intraperitoneal, and intrathoracic on the right, as well as a small pericardial fluid collection. But there's a lot of information that can be obtained from this subcostal window before you even get to the heart in terms of visually estimating the inferior vena cava size and looking for large intraperitoneal or right pleural space fluid collections. So now we're at the level of the heart, and now we're going to be looking for hemopericardium. Now using these CAT scans, you can see that the fluid collection here was a patient with a smaller pericardial fluid collection, but still it has to fit the shape of the container, and it basically here surrounds the heart. Here you have a patient with a much larger pericardial fluid collection, and again you can see that it's contained between the parietal and visceral layers of the pericardium, and it follows around the border of the heart. Now let's first start by looking at a very large pericardial fluid collection. Here I've got the depth set to a very large field of depth so that you can see the entire area. But if we take a look here, this is a subcostal window. You've got the right side of the heart. There's going to be right ventricle, right atrium, left ventricle. And what you're seeing here is that there's a large anechoic fluid collection that's surrounding the heart. And you can see that it fits the shape of the container, and it's between the visceral and parietal layers of the pericardium. Remember, anything on this side of the diaphragm here is going to be intraperitoneal. And remember, depending on how you have the transducer angulated, you can bring in some of the left pleural space as well as the right pleural space. So remember, you just have to make sure that this fits the shape of the container. Now here's another patient with a large pericardial fluid collection, and you can see here that there are some echoes within there, but you're using the liver as a window, right side of the heart, left side of the heart, and you can see that this fits the shape of the container and is surrounding the heart. In addition, this patient has premature diastolic collapse of the right ventricle, which would be a finding of tamponade physiology. We're going to go over that in greater detail in the cardiac module, but you can see that there's clearly a large pericardial effusion here. Let's take a look at this patient who was stabbed in the chest. You got liver as a window here. You see this big echogenic space before you get to the heart here, so this should clue you in to the fact that there's something wrong here. You can see right side of the heart, left side of the heart. What you've got here is a very large echogenic effusion. Of note, and again we'll talk about this in the cardiac module, you don't even see filling of the right ventricle. This patient had tamponade physiology also. But you can see there's a very large echogenic fluid that fits the shape of the container. It's surrounding the heart here. And this patient, when they were taken to the operating room, had almost 400 cc's of clotted blood within the pericardial sac. Now here's a patient with a moderate pericardial effusion. Again, the smaller the effusion is, the more carefully you're going to have to look to make sure that this fits the shape of the container. But you can see here's liver. So this would be diaphragm right here. There is no fluid on this side, but you can see that there is a medium level echogenic space here surrounding the right side of the heart. And you can see on the video clip that this is extending over to the left side of the heart, and it fits the shape of the container. This was a patient who had also been stabbed in the chest and had hemopericardium. Now here's a patient that has a small pericardial effusion, and you can see between the visceral and the parietal layers of the pericardium, you can see that there's a very small space that's surrounding the heart. This was not a trauma patient, this was a medical patient, but you can see that there's a very small effusion here, and you can see that it's also on the left side too. So the smaller the effusion, the more likely you are to miss it, and that's true whether you're a novice scanner or a more advanced scanner. So you're going to have to look very closely when doing these windows. What are some of the pitfalls? Now, anything that causes an anechoic or echogenic space around the heart is going to be at risk for being called a pericardial effusion. I want to go through some of the more common things that you're going to come across that could cause a diagnostic dilemma. One of the big things is an epicardial fat pad. Now these are common the older we get, and these are isolated along the right side of the heart. Since these contain fat, you would expect that these would have a fixed structural appearance, unlike blood, which would be swirling within the pericardial space. So here you can see this echo pore space, there are some echoes within there, but note that there's a fixed appearance of these echoes between systole and diastole. That would help you to differentiate this from an echogenic pericardial effusion. Now, there are times where you're not going to be able to differentiate on the subcostal window whether this is a fat pad or an echogenic effusion. In those cases, you're going to go to a backup transthoracic window, and we'll go through the parasternal long axis in upcoming lectures. Now, here's a comparison. Here's a patient with an echogenic pericardial effusion. You can see that the echoes within there do not have a fixed appearance between systole and diastole. And you can see that this extends over towards the left side of the heart. And here you've got the patient with the epicardial fat pad. Again, note the fixed appearance of these echoes between systole and diastole. That's going to be the key point to help you in differentiating a fat pad from an echogenic effusion. Now, pleural effusions can also be a cause for diagnostic dilemmas. If you take a look at this patient, as we're scanning into the chest and following the inferior vena cava, you can see that there's this anechoic space here, but this doesn't fit the shape of the container for a pericardial effusion. It's not surrounding the heart. It's going off to the side here. But if we look further, you can see that the patient does also have a pericardial effusion. So it's important, even if you notice this pleural effusion, to keep looking for the pericardial effusion. But remember, it's all about the shape of the container. Now here's a patient that has a very small right pleural effusion. If you look, here's the liver, here's your diaphragm. You're going to use that as a boundary. You can see that there's an anechoic space here on the cephalad portion of the diaphragm. So this would be within the pleural space. This is the patient's right, so this is a right pleural effusion that's very small. And here's the heart over here. Let's take a look at ascites or hemoperitoneum, since there is an intra-abdominal window here. So here we are on a subcostal window scanning into the chest. You get your liver here, here's your diaphragm, here's your inferior vena cava. Now, as we get to the heart, you can see right side of the heart, left side of the heart. You see this anechoic space here, so that should right away clue you in that maybe there's a pericardial effusion. But as you look at it closer, you can see that it's on this side of the diaphragm and it's following along the border of the liver. So this would not be a pericardial effusion. This is an intra-abdominal fluid collection. And we'll look at it one more time. There it is right there. So let's take a look at this window, subcostal window, and try and determine all the fluid collections present. So if you look here, you see right side of the heart, you see left side of the heart. You can see here are the visceral and parietal layers of the pericardium. So you see that there's an anechoic space between those two layers that surrounds the heart. So there's a very small pericardial effusion present. You follow the boundary here of the diaphragm, and on the caudal side of it, closer to the transducer, you can see that there's also a fluid collection. So this would be intraperitoneal. Now, if you look adjacent to the left side of the heart, you can see that there's also a relatively large anechoic space. Here you've got the lung right here. So this would represent a large pleural effusion on the left. So this patient has 3 fluid collections noted: left pleural effusion, pericardial effusion, and intraperitoneal fluid. So remember, you've just got to define boundaries and look at the shape of the container where that fluid is. And that's going to be the most important thing in helping to minimize over or undercalling the presence of a pericardial fluid collection. So let's sum things up here. Fluid is going to be formless and shapeless, so you've got to assess the shape of the collection. Hemopericardium can be either echogenic or anechoic. In the trauma patient, size doesn't matter when evaluating hemopericardium. And do the parasternal long axis window when you can confirm whether it's hemopericardium or a fat pad. And we'll go through that in a future module, how to perform the parasternal long axis window. At a minimum, you need to do serial exams on these patients with ultrasound to determine if there's any change in the size of the fluid collection when you're unable to confirm hemopericardium or fat pad.